Valdivinos. So I am going to talk on polypectomy, how we do it. Polypectomy effectiveness is very important because up to 20% of interval cancers may be due to incomplete resection. And in the CARE study, high rates of incomplete hot snare resection of non-pedunculated neoplastic polyps was seen. Also, there was significant variation among endoscopists, and serrated polyps were 4 times more likely to be incompletely resected. Other studies have raised issues with effectiveness of resection with biopsy forceps. So there's a lot we can do. So let's first look at resection of polyps less than 10 millimeters. Those are 90% or more of the polyps we take out. So what about cold forceps? Most studies suggest not using it, but consider it when a polyp is inaccessible for efficient snaring. And the reason is it's associated with high rates of incomplete resection. Therefore, it's best for small, very small polyps, less than 3 millimeters. And you should use a jumbo or large capacity forceps. I'll just briefly mention the hot biopsy forceps, which is not recommended because of complications and incomplete resection. So here you can see how I recommend using the jumbo forceps. The polyp should be very small, and so that you can take it off with one bite. You don't want to take off a polyp larger that requires multiple bites. What about cold snaring? Well, really, this is the preferred technique, and it has little risk. It's safe in patients taking antiplatelet agents or anticoagulation, and it allows for immediate visualization of complete resection. And the technique, usually you'll use the smaller snares. I like the stiff snares. It's fundamentally different from hot snares because you want to ensure 1 to 2 millimeters of normal tissue, and the snare sheath therefore should remain embedded in the colon wall during closure. And as you can see here, you want to press the snare down so that you get normal tissue, unlike you do with a hot snare where you raise it. But here you can see I'm putting the forceps around it. I'm trying to get normal tissue there, and so that, and then cut. And if you do that, that's always going to be the best technique. That's very different than the hot snare technique, where you're going to lift the polyp. You're going to get the base of the snare there, lift, and then burn. What about pedunculated polyps? Again, usually we perform with a hot snare. You try to position the scope so that the polyp is hanging down, and you position the snare around the stalk 1/2 to 1/3 the distance to the colon wall. You want to leave sufficient stalk to regrasp in case you get bleeding. And once snared, again, you lift away from the colon wall. We usually recommend we use forced coagulation if you're concerned about very big, large vessels, because you want to burn that and you don't want to cut through them. And for large lesions, minimize contact with the opposing wall. So here I'll show you, here's this fairly sized polyp on the right, and then what you do is you position the scope so that the polyp is actually hanging down, and that way you have room to work. You can position the snare around the polyp, and then again use the hot snare to resect. And usually make sure that if it's touching the opposing wall, you're shaking it to avoid any thermal contact. Now, with large pedunculated polyps, where the head is greater than 20 millimeters or the stalk's greater than 10 millimeters, these are often fed by multiple large vessels, which can cause bleeding. So the strategy to reduce bleeding is to either use an endoloop, you can use clipping, you can use volume reduction techniques with epinephrine, or as I mentioned, you can use forced coagulation. So here is an example of using the endoloop if you're worried about it, where you put the endoloop on first, and that causes constriction. And then once the endoloop is on, then you can put the snare around it and then remove the polyp, and that endoloop stays on and provides protection. The other technique is to use clipping. And so before you remove the polyp, you can put 2 clips, as you see here, then remove the polyp, and that also is another safe technique for, again, removing large polyps with large vessels. Now, serrated polyps are the area where I think there's most concern about the development of interval cancers. And they tend to be flat, subtle lesions with indistinct margins. Incomplete resections are high. And although the optimal resections techniques have not been established, cold snaring is still suitable for lesions less than 10 millimeters, EMR for larger lesions. It's really important to delineate the margins prior to resection. And to do that, we use image enhancement techniques like topical dye spray, NBI, or submucosal injection of dilute indigo carmine. So here you can see what it looks like using NBI. Here is one of those sessile serrated polyps, somewhat difficult to see. I think NBI can be beneficial. It gives a little more delineation, but really injecting it with indigo carmine-based dye really lets you see the margins much better. And so the guidelines do recommend this technique. And in this next video, you'll see the difficulty in identifying these serrated lesions. This is where I'm using a cap, and you can see right there the difficulty in finding some of these sessile serrated lesions. And in my previous talk, I mentioned the importance of doing at least a double right colon exam. And this is an example where this was on the withdrawal the second time that we picked up this sessile serrated lesion behind a fold. And you really have to spend time looking. Some people like the cap to help do this. So here you can see we positioned the lesion in the 6 o'clock position. Still, this is a little bit of NBI. It helps to see this a little bit more, but because of the size, this is an ideal lesion to inject first with indigo carmine solution, and then it raises up, does a submucosal lift, which you'll see here, and then you can more safely resect it, and you also get a much better look at the margins. So here we're going to lift it in the submucosal region here. You can see how the dye helps to bring out the margins more so than without. And then once you've done that submucosal lift, then you can easily grab it with a snare. Again, I prefer a sniff type snare because it grabs it better, and then you can then take it off. I use this particular case because you can see right here some additional tissue was left, so you have to inspect it very carefully. And in this case, you want to use the snare to remove residual tissue. You don't want to use APC because it has been shown not to be as effective. So you want to either use a snare to take the residual tissue off, or use what we call the avulsion technique with the hot biopsy forceps, and then you'll get removal. So talking about this submucosal injection, you can use just normal saline and epinephrine. The problem is it's quickly absorbed. For small polyps, you can do that. But for larger polyps, more viscous agents are better, and for polyps greater than 2 centimeters, you probably want to use that. There are a lot of options, and so this new Elview is a premix solution with methylene blue that is good. And so the viscous solutions work well, and we recommend a dynamic submucosal injection where you're moving the needle so that you get the proper lift that you want. And the principle behind it is if you have a lesion like this, you can inject the submucosal area, and then for large polyps do submucosal injection, and you're protected by that injection. Now, the important thing is, if we move on now to these large non-polypoid colorectal neoplasms, and to avoid residual tissue, you have to really inspect it. So you want to first make sure it's as best you can that it's limited to the mucosa and the submucosal, which is less than 1,000 microns. Because if you have deeper submucosal invasion, then you either want to send it to an expert center or surgery. And then you want to characterize it endoscopically with regard to size, shape, mucosal pit pattern, vascular pattern, and remember to do EMR for size greater than 20 millimeters, which means injection. And when you're doing the macroscopic characterization, you want to look at the Paris classification as one, remembering that type 2 and type 2C and 3 are a high risk of advanced histology. And remember that we define flat lesions greater than 10 millimeters as lateral spreading tumors, and they can be granular or non-granular. The granular ones have a low risk of cancer, whereas the non-granular have a high risk of cancer, and if it's non-granular, again, should be referred to an expert center. And then you can do microscopic characterization with NBI and Nice, remembering that the type 3 Nice shows deep submucosal invasive cancer, otherwise the Kudo VN, and indigo carmine can also help define depressed lesions. So this is the Paris classification, and again, if you see a 2C depressed lesion or certainly an excavated lesion, there's going to be a risk of submucosal invasion. And then the Nice classification, it's the type 3 that has distortion or absence of pit patterns and is associated with deep submucosal invasion. So in this case, you can see this large polyp, and once we saw this area, which is irregular microvasculature, it's darker, this indicates submucosal invasion, and we referred to a surgeon. Inspecting with the snare can be very useful as you're trying to characterize the polyps, and you want to look in front of it like we're doing here, but you also want to use the snare to look behind it so you know how much tissue you have to take off, and you can see the tissue goes pretty far back here. So you have to know that before you remove the polyp. Indigo carmine can also be very useful, and we use this quite a bit, and it emphasizes depression and protrusion of uneven surfaces. It's easily washed away. And so here you can see in these examples, this area here it turned out to be high-grade dysplasia. It was very difficult to see with white light alone, but with indigo carmine helped outline that area a little bit more. So for these lesions, at least 2 centimeters or greater, you want to use what's called the inject and cut technique, where you bring the lesion to the 6 o'clock position, inject the fluid. Lesions less than 20 millimeters can be removed in block. If they're in the rectum, it can be 25 centimeters because of the thicker wall, and that's associated with lower recurrence rates. Lesions larger than 20 usually require piecemeal resection. And again, recommend a stiff snare and use the snare to remove residual tissue and apply APC to borders if you just want to protect that. And then follow up these large lesions at 6 and 18 months. And in terms of electric cautery, it's recommended that you use a microprocessor-controlled electric cautery generator like Irby. And then there are specific, for hot snare or EMR, it's recommended the EndoCut Q, for example. If you're going to use the snare tip, you want to use soft coag. As I mentioned, where there's scars or it's hard to get it, you can use the hot biopsy avulsion technique, which is EndoCut 1. And then for large pedunculated polyps, you want to use forced coag, which on Irby is the blue petals. So these are set techniques. But the inject and cut technique is relatively simple to learn. And again, you can, for these lesions that are 20 millimeters or less, you can almost always, after you inject, you can almost always, using the right snare diameter, you can grab the tissue, and take enough that you can, you've got the borders, and then you can easily and safely cut it. Now, sometimes you do get muscle, and as you'll see here, you can tell the muscle by the thicker white area in here. This is a little bit of muscle injury, and if I see that, then I will clip it to prevent delayed perforation. And one thing to remember is if you go, normally it should lift easily. If there's a non-lifting size, it usually is a sign of invasive neoplasm or submucosal fibrosis. And if I get the non-lifting sign, then you want to refer to an expert center. The in-block polypectomy is really the best way to go because we know otherwise there are high recurrence rates. And again, you can do it for lesions that are less than 20 millimeters. And if you can get a good lift and you know that you've got a good submucosal layer, then even these large lesions can come off in an in-block fashion. And the more you can use the in-block fashion, the more likely you're going to be able to avoid residual tissue. And so again, in this case, as long as you can get the snare around it, then it should be safe. Dr. Valdovinos, what does it say here? Something popped up here. Yeah, okay. And so here you can see the snare coming, getting around it, and again with the submucosal injection, you can safely cut that off. And on these large lesions, though, we'll tattoo them and then also recommend surveillance at 6 and 18 months. Complications, just to go over, you want to be prepared to manage bleeding and perforation. And this, I mentioned this is called the target sign. And that's the benefit in using the dye, because if you get the dye in here, you can see normally the base should be blue. And if you see a thick white structure like this is the classic one called the target sign. Sometimes the lines can be just straight. But if you see this, it indicates a risk of delayed perforation. And so if possible, these are ones that I clip. And then the other risk, of course, is bleeding. And this can be intraprocedural or delayed. Intraprocedural bleeding occurs in up to 11% during EMR. And usually, if it's mild, you can treat with the snare tip or soft coagulation. But sometimes we will use clips, as you can see in this particular picture. It can be difficult to use a clip if you can't actually find where exactly the bleeding is going on. The other option is to use the coagulating forceps for more severe cases. And then remember that post-polypectomy bleeding occurs in 7% and usually within 48 hours. And most of these can be managed conservatively with supportive care where you don't have to go in and do a colonoscopy. And if you do go in and do a colonoscopy, we usually will inject with epinephrine and then try to put clips on. So this is sort of a summary of what I've said in the last minute and a half. So you really should develop a systematic approach in your institution. So when you get a lesion, size next to the reference point of a known diameter, particularly the snare diameter. Use the Paris and the lateral spreading tumor classification. Make sure you examine the surface pattern with high definition chromoendoscopy. To look at the morphology, you want to use the Paris classification. You want to, in non-granular lesions or granular lesions, look for any dominant nodules and resect them separately. Understand the Kudo pattern and Nice type 3. Look at the gross morphology before you do it. For non-invasive lesions, you try to do an en-bloc resection, piecemeal resection if you can't do that. And for lesions that are large or difficult or certainly greater than 40 millimeters, refer to an expert center. If you suspect mucosal invasion and that's based on the 2A, the 2C, or the 3, or the Nice type 3. If you suspect submucosal invasion, then you should really consider referring the patient to an expert center or doing an en bloc resection. The other option is surgical resection, and always, if you're going to send it, make sure that you tattoo it about 3 centimeters distal to the lesion. And with that, I will end. So in summary, understand when to perform cold polypectomy and when to proceed with hot snare. Learn how to best characterize non-polypoid lesions. Really become familiar with the Paris and the Nice classification. Know the indications for EMR with inject and cut. Understand injection and cautery techniques, and be able to manage complications. Thank you.